if you'd like to, and mute yourself if you'd like to do that. Lydia, I'm going to ask you if you would to please, while we're getting going, get a hold of Eleanor and help her log in. She's having some trouble, I think. If you can help her, that'd be great. So anyway, Vince Markovchick is a wonderful, I first saw Vince speak in, gosh, it's probably been 2007 now. That's a few years. Vince was for many years the head of the emergency department at Denver Health, which is no small order in a big city like ours, at one of the busiest hospitals in the level 1 trauma center. So he has a lot of experience in this area, and I've always known that I learn a lot, but I also grow a lot when I listen to Vince. He makes it humorous, fun, and interesting. So with that, Vince, take it away. The show is yours.
Thank you, Donna. Well, I'm going to get started here in a minute. I just need to let people know why I even got interested in this subject back in the early 2000s. You know, after working in an emergency department for 15 years or so at that time, 20 years at that time, I suddenly realized a lot of people were asking. They come in with a very serious illness or injury, and they say, how am I going to pay for this? How am I going to pay for this? And many of them were working. Many of them had no insurance, obviously, even though they were working. So I started wondering why in our country, the richest in the world, we had people who couldn't afford healthcare. And so I started these series of talks on this. Way back then when Donna saw my first talk, I titled it The Perfect Storm, because I thought our healthcare system was headed toward implosion. And you know, it still is headed in that direction, and we're going to go through this. So let me go through. Okay, that's me. No financial conflicts of interest of any kind. I'm not taking any money from any special interest lobby. And I think George Carlin got this kind of right here when he said this. I don't believe there's any problem in this country, no matter how tough it is, that Americans, when they roll up their sleeves, can't completely ignore, although we've done a good job trying to ignore this for a long time. So in the first session today, excuse me, we're going to answer the question, how healthy is our healthcare? We're going to talk about some of the models of healthcare systems around the world. We'll talk about what our model is. We'll discuss in some detail the background here to understand Medicaid, Medicare, Medicare Advantage, private health insurance, and Obamacare. So we got a fair amount to cover. I'm going to go quickly through a lot of this. We will have time for discussions. Please, as we go along, feel free to put your questions or comments in chat. And hopefully at the end, we'll also have time for people to actually verbalize their questions or their comments. Session 2, this one just starts giving you some chest pain, that we're going to follow the money. What do we do with $3.8 trillion every year, where it comes from and where it goes? We're going to find out the source and how we spend these funds, and how much, and this is going to surprise you, how much is actually spent on healthcare, and what it costs individuals and families. Why does it cost so darn much? And can the average person afford it? And we're going to get into surprise medical bills, which often lead to medical bankruptcy. Session 3, now this one will really give you chest pain. We're going to talk about waste, fraud, and abuse, which is rampant. Whenever you got $3.8 trillion floating around, you can imagine what's going on here. And we're going to talk about how much does this cost and what kind of things can be done about it. And in the last session, we're going to talk about how can we achieve the ideal health insurance and healthcare system? And we'll talk about current proposals to reform the system, the current system. And we'll talk about the case for publicly financed, single payer, enhanced, improved Medicare for all. Fundamental question we should be asking ourselves in regard to healthcare is, Eleanor entered the waiting room. I'll click admit. Whoops, it won't let me advance here. Let me
Yeah,
see.
just admit her. Just go ahead and
I
admit
did.
her. Vince.
Okay, so
There.
the question is that we as a people have to decide if we believe healthcare is a basic human right or it's a commodity to be purchased by those who can afford it. Every other country in the developed country in the world has decided healthcare is a basic human right, and they provide basic universal healthcare to not just their citizens, but in virtually every country to all residents. So how healthy is our healthcare? Let's look at this question first. And do we have the best healthcare in the world? If you listen to many of our political leaders, that's what they say. Keep the government out of our healthcare. It's the best in the world, and the government will just mess it up. And we've already got the best. Well, do we really? Well, the answer is yes and no. If you're in the right place at the right time with the right resources, you can get the best healthcare in the world. For example, if you suffer major trauma in Denver and you get picked up by the Denver paramedics and taken to Denver Health, we have, the time I was there and it's continued, a 95% survival of anybody who arrived with any vital signs. That's as good as any trauma center in the world. But that's just not the reality of everybody. The Commonwealth Fund does a very nice survey every year that they've been doing for 12 or 13 years now, and we've consistently been last. We've been last in the healthcare system ranking, and here it is. You can see we're number 11 overall. The only thing we scored high in is care process, and that has to do with the large amount of technology we have in our country. I mean, we've got a CAT scan on every corner. We've got all kinds of technology, and other countries don't have as much technology as us. That's why we scored. They have the technology, they just don't have as much of it. So here we go. Avoidable deaths, we're last. You can see we're an outlier. I could add this maternal and infant mortality. We are an outlier. We are the worst in the world among these other countries. That has to do with inequities in healthcare and as well as access. Healthcare spending, we're at the top. This is a percent of GDP. We're up to 18%. Healthcare system performance scores, we are way off here in terms of affordability compared to other countries. We are certainly number one in spending. And let's just define a couple terms, because it makes me kind of crazy to hear a lot of our political leaders screaming about socialized medicine and how evil it is. They don't even know what it is. They literally don't know. Socialized medicine is a system where the government owns and operates the hospitals, and the providers, doctors, nurses, and everyone else are government employees. So they start talking about Obamacare, and they start talking about Medicare, and they claim it's socialized medicine. Well, it's not. What is socialized medical insurance? It's a system where the government collects taxes to fund medical care. And examples of this are Medicare, Medicaid, the state children's health insurance program, but they're government funded, and we'll get into that funding in a little while here. But most of the care is rendered by private hospitals and private doctors. So that's a social medical insurance program. And that's what Medicare is. We'll get into examples in a minute. In terms of world healthcare systems, there's basically 4 models, actually 5, and we're going to get into those now. The beverage model is true socialized medicine. The hospitals and clinics are government owned. The doctors, nurses, and all the other providers are government employees, financed through some type of tax revenues or assessments or however they do it. Countries that have this: Great Britain, New Zealand, Spain, most of the Scandinavian countries. And this is systems that work very, very well. People in Great Britain of all political persuasions love their health system. They wouldn't trade it for anything. Bismarck model, this goes way back to the 1800s in Germany. The Germans established this, but these were sickness funds, funding insurers, financed jointly. The funds come jointly from an employer and employee payroll deductions. The difference between what we have and this is this money insures everybody, not just people who are employed. All of these are nonprofit. They must cover everyone. Most of the doctors and hospitals are private, but it has very tight government control of payment and costs, which is why they can do it so efficiently. And they work well. Countries: Germany, Japan, Switzerland, France, and the Netherlands. Switzerland we'll get into later, but they have the next highest cost of medical care because they do run everything through private insurers who are very tightly controlled. The national health insurance model, funded by mandatory premiums or taxes, private sectors, providers, hospitals, and doctors. And this is the social health insurance model. And this is countries like Canada, South Korea, Taiwan established theirs recently in 1995. And US original Medicare, not Medicare Advantage, and Medicaid. These are social insurance programs. The out-of-pocket model, that's where you got to pay for your own medical care with your own funds, found in all underdeveloped poor countries and in the uninsured and uninsured people in our country. So we have a model similar to the poorest countries in the world, where people have to pay out of their own pocket, and if they don't have it, they don't get care. Here's the dates for universal health care. Going back to 1912 with Norway, and you can see single payer insurance mandates. And then there's what's called a 2-tier, like in the Netherlands. That means they have a national health plan in which doctors and hospitals are owned by the government and provide care. And they also have a system of private hospitals and private providers for people who want to go beyond and can afford that level of care. Personal experience, my wife became, it was personal experience in Denmark. When my wife became ill, Denmark has a 2-tier system. My wife became ill on a trip. I took her to one of the government-run hospitals in Copenhagen, not the private. It was an antiquated hospital. And when I checked in, I said, how do I pay the bill? They said, you're tourists from the United States? We said, yes, just give us a copy of your passports and we don't charge you because you're tourists in our country and we'll take care of you. She was there 3 days and we got a 0 bill. And you can see all the other countries. The one that's not on here is Taiwan. That was established in 1995. And it was designed and set up by 2 people from our country who consulted with the Taiwanese, and they had the political will to do it, and they were able to pull this off in about 1 to 2 years. And now they have a fully functional Medicare-like national health system. So what kind of care system do we have? We have a combination of all four. The beverage is the US public health, native health. It's where the government owns the hospitals. And Denver Health actually is socialized medicine, where I worked, because it was a government hospital, hospital and clinics were governmental, and all of us were on a salary. Bismarck, that's the employer-based private health insurance that about 150 million people are covered by now in the US. The national health insurance, that's Medicaid and Original Medicare. That's the social insurance program. And so do we really have a healthcare system, or is it a healthcare marketplace? We don't have a system. It's totally fragmented. The system implies a single way of getting things done. We have a fragmented, disjointed, screwed up, messed up, what people call a system, but it really is a marketplace. So the beginnings of our insurance system go back to before World War II. And during World War II, Blue Cross, Blue Shield, originally formed way back then. Blue Cross paying for hospitals, some hospital bills, Blue Shield for doctor bills. During World War II, people had their employment frozen because they really needed people to work in industries to support the war effort. And they couldn't go to shop around to go to different jobs. So the way employers attracted people was they started offering health benefits. And that's how our health insurance got tied to employers. The IRS later passed a rule where it said, or a law that said the contributions by the employer for the health insurance is tax deductible. And it made it more attractive for employers to start paying for health insurance. Commercial life insurance companies began selling health insurance. And then in 1965, this was the big year, Lyndon Johnson was able to get through Congress a bill establishing our original Medicare system for all those individuals over 65 years of age, and Medicaid for the poor, for the people below the poverty line for wages. We remain the only industrial nation without universal access to care. We cover the elderly people pretty well, very well, and it's patchwork how we do Medicaid, and we'll get into that. And so we're the only country where most private insurance is directly linked to the employer. And you saw the real problem with that when COVID hit and people started losing their jobs. You lose your job, you lose your health insurance, and you're in big trouble. And it's because it's linked, and there's other problems with that, such as people can't move to other jobs because they're tied to their own health care through their own employer. And that creates, it's not a good situation. And we'll get into more of that. Elizabeth Rosenthal wrote a book called An American Sickness. And she made it, she makes a good case for saying American medicine in a little over a quarter of a century evolved from a caring endeavor to the most profitable business in the United States. And now much of our healthcare is provided by business entities whose primary focus is making a profit, and the secondary focus is funding healthcare. So what is Medicaid? Well, that's a social insurance program funded either 60% by the federal government, 40% by the states, or more recently expanded Medicaid is funded 95% by the federal government, and that should be 5% by the state governments. The important thing to know about Medicaid is it's a national program, but it really isn't, because each state determines their own eligibility requirements and they administer their own Medicaid insurance program. And so it really is very different from state to state. And we're going to get into that. So Medicaid is a very important part of our healthcare system or marketplace. 1 in 5 Americans, about 75 million people now, are covered through Medicaid. And you think, well, that's just the poor people or the people who don't want to work that get Medicaid. Well, that's not true at all. Greater than half of the Medicaid dollars funds long-term care, because this is the way most people are able to go to a nursing home and have some funds coming in. But it's a very bad way to do it because they have to become indigent to qualify. It certainly is an important part of our safety net, Medicaid. Denver Health, where I worked, probably 40% of the patients we saw, or 50%, were on Medicaid. And at least they had that insurance. So who's covered? Well, it's up to 80 million people, about almost 2 million in Colorado. A large number of children. There's a way to get children covered even if their parents don't completely qualify, and that's the SCHIP program. And then anybody who's declared disabled through Social Security is eligible to be covered by both Medicare and Medicaid, and they are dual eligible. And the reason why Medicaid is good is because with Medicaid, you don't have any copays or deductibles. With Medicare, you do, and we're going to get into that. So the completely disabled people can avoid copays and deductibles. And it's covering now about 2/3 of those in nursing homes who are mostly elderly seniors. And the Medicaid spending is mostly for elderly and the disabled. You can see the enrollees. The aged are only 9%, the disabled are 12%, but they consume, the aged 23% and the disabled 34% of the total Medicare dollar. Okay, and you can see the expansion of Medicaid dollar. Expansion of adults goes from 21% covered, but only 17% of the funds. And we're now up to, this is a slide from 2020, we're up to $560 billion a year to fund Medicaid. And then there's been the Medicaid expansion under Obamacare, Patient Protection and Affordable Care Act. What that did when Obamacare went into effect in 2010, it increased the eligibility for Medicaid from 100% of federal poverty. They raised it to 138%. And that was a big deal. A lot more people qualified. And the law said that every state had to do this, increase the Medicaid rolls. And the perk was the federal government was going to fund 90% of this increased eligibility people, and the states would be responsible for 10%. And so it was a good deal for the states because they would only have to fund 10%. This was then taken to the Supreme Court in the first lawsuit over Obamacare. And the Supreme Court said the law, federal law here, could not mandate every state increase the eligibility to 130% of federal poverty. They could determine it on their own. So a large number of states initially refused to expand Medicaid, and we still have 12 states who are refusing to do it. And we'll get into the poverty levels with another slide. So right now, with the American Rescue Act, the federal government is funding 95% of expanded Medicaid, and we still have 12 states for political reasons that refuse to expand Medicaid. We have 5 to 6 million people who would be eligible who have no health insurance. And even just as bad, think about the providers in Texas and Florida. These people still arrive at the emergency room in the hospital for medical care, but the hospitals and doctors don't get paid. And this is the big reason why rural hospitals, over 85 of them, have closed in the last 5 or 6 years, or last 10 years, simply because they couldn't get funding. I don't understand it, but that's the way it works. Here are the hospital or the states that have refused to expand Medicaid. They're mostly in the South. The two biggies are Texas and Florida. Even Wisconsin has now Missouri was really holding out and refusing until the citizens put on the ballot about a year ago a referendum to mandate that the Missouri legislature and governor get into the expanded Medicaid. And it passed. But the legislature refused to fund their 10%. And so it now went to the Missouri Supreme Court, and the court says you have to expand Medicaid in Missouri, but it still hasn't happened. This is crazy. Well, anyway, we're getting into the COVID stuff here. And this is just amazing what's happening in our country. Okay, and we'll be into some questions here in a minute. What is original Medicare? The one that was passed in 1965. Well, it's the healthcare and social insurance program run by Center for Medicare Services. That's a part of Health and Human Services. It provides Part A, which is hospital, Part B, doctor coverage. The important thing here is in original Medicare, you can see any doctor or hospital that accepts Medicare, and 95% of doctors will accept Medicare. And virtually every hospital, unless there's some private boutique hospital, will accept Medicare as well. So when you hear the politicians screaming about, you can't expand Medicare because it's going to take away our free choice of doctor and hospital. It does exactly the opposite. It gives you a free choice. You've got to pay premiums. Part B and Part D are premiums charged to people on Medicare. Part A is usually premium free, and I'll show you why. And and this is a problem with original Medicare, deductibles, coinsurance, and co-payments, which makes it unaffordable for some. And Part D, we're going to get into in a minute here. Sorry about this. Okay. In 1945, President Truman actually proposed a national health insurance program. And he said, we need health security for everyone. Every resident, he didn't say every citizen, he said every resident, regardless of station. And this was right at the time Great Britain established their National Health Service. So Great Britain did it. President Truman wanted to do it. He knew there was a need. But the big opponents to this kind of thing was actually the American Medical Association. Now, when Medicare was enacted in 1965, this is President Johnson with former President Truman in Truman's office in Missouri, signing the Medicare law, and Harry Truman got the first Medicare card. It's right here. And no computers, no technology back then. Within 1 year, they had issued cards to every single person covered by Social Security, and they had Medicare. And it really happened that way. Now, wow, complicated. One of the big persons lobbying against Medicare was Ronald Reagan. And the whole screaming deal here was socialized medicine. If you read that quote in the upper right, you know, you would swear that we were really going to heck in a handbasket. Medicare was just going to make things so terrible for us and it'd take our freedom away. Well, they're still screaming that stuff now. So who are enrolled in Medicare? We're up to 2019, 62 million. We're now up to 64 million, a cost of over 800 billion. The average payout for a Medicare enrollee is 14,000. And about 1/3 of people in Medicare are enrolled in Medicare Advantage, which is private insurance. We're going to get into that. Come on. There we go. You can see with the baby boomers aging, and we're really rapidly climbing in terms of the number of people who will be over 65 or disabled and be on Medicare. And you can see only 14% are under 65, and they are primarily the disabled, and everyone else is over 65 covered by Medicare. It has 4 parts. A is hospital insurance, B is medical, which is doctor and physical therapy and other types of provider care. Part C is Medicare Advantage, and that's private insurance funded by Medicare. And Part D, which we'll get into, is the Medicare prescription drug program. You're automatically enrolled in Part A and B when you claim Social Security. And it's very easy to get this to happen. And the government's very smart. They collect the premiums by deducting them from your Social Security check. So there's no hassle about billing and collecting here, is there? Now, you could opt out if you want. That would be your decision. You could say, I don't want Medicare, and then go on your own for health care. Part A is funded, the hospital part, funded primarily by payroll taxes, which is 1.45 by the employee and employer, all of it if you're self-employed. And in 2013, they added an additional 0.9% on for anybody making over 200,000 a year. And you can see how the Medicare payroll taxes in 1970 were funding more than half of all of Medicare. Now they're only funding 25%. The general tax fund is funding most of it. And here you can see Part A, the orange is the payroll taxes funding Part A. The 72% is general tax revenues. And the this color is Medicare premiums. So you can see Medicare premiums do not fund very much of Medicare. And the benefits here, what I want to call attention to is this orange. This was Medicare Advantage being paid for by Medicare. It's doubled in 10 years, and it's now up to probably 35% of the Medicare dollar. And we're getting into why that's a problem later. This is a little bit of an older slide, but this really surprised me. If you look at Social Security people, Medicare beneficiaries, how many of them live on their Social Security check? And look at this, 50% had incomes below 26,000 a year. And 25% had incomes below 15,000 a year. Now they were covered by Medicare, and premiums are being taken out of their Social Security. But think about the amount of money these people are taking in every year and how much medical care will cost even with Medicare. And this is savings, 50% savings below 74,000. And you can imagine how quickly that could be wiped out with some really big medical bills. You compare that to the cost of Medicare. You pay your premiums and they're graduated depending on your income, but you still have to, for your hospital stay, pay $1,500 during that year as a deductible. No dollars for the first 60 days. You're in the hospital more than 60, you're up to $371 and even more later. That's a problem with Medicare. That has to be fixed. If you have to go to a skilled nursing facility or nursing home, Medicare only funds the first 20 days. After that, from 21 to day 100, you got to pay $185 a day. And then after that, all costs are yours. Look at the Social Security guy living on $26,000 a year. Where's he going to come up with any of this money? And that's the flaw in Medicare. So how, and then of course, Part B, that's the other problem. That's the doctor bills. The deductible is only $203, but you have to pay 20% of the doctor's charges. So the surgery costs $1,000, the surgeon's fee, you're responsible for $200. And a lot of people can't afford that. And of course, the same thing with durable medical equipment, and all this equipment is way overpriced, and you've got to pay 20% of that. And here's how the premiums work. It's based on your last year of income. So our 2021 premiums are based on actually the 2019 tax year. And they go from $148 to $500. And this shows the Part D for the drug coverage, which is a lot less. So the other question now is the Medicare Trust Fund. How healthy is it? When's it going to run out of money? Well, the projection now is it runs out of money in 2026. And so we've got to figure out ways for existing Medicare to improve the money going into the fund. The solution that the private insurers have figured out to help people with all those copays and deductibles is to have people buy Medicare supplemental or Medigap insurance. So that's a supplemental policy, covers all or some of the copays, deductibles, and coinsurance not covered by original Medicare. This is not subsidized. This comes right out of the individual's pocket. And many people who can afford it are buying these policies. So to be eligible, you must be covered by original Medicare. The nationwide average cost is between $143 and $300 a month. Every year you age, your premium goes up, depending on which policy you take. And the sweetener here is to get you to buy it. They may offer additional benefits, and we're going to get into those with Medicare Advantage that Medicare doesn't offer. Medicare covers no vision in terms of eyeglasses, no hearing aids, no dental care. And so you pay the private insurance premium, the cost will vary, and it doesn't work with Medicare Advantage. We're going to get into that. Important thing here, with virtually every one of these plans, you have a free choice of doctor and hospital because you have original Medicare. That's who's paying most of the bills here. This plan is simply covering your copays and deductibles. Now, the important thing that most people don't know about Medicare supplemental insurance. When you go on Medicare at age 65, you can enroll in any Medicare, Medigap plan that's out there, and they cannot refuse you. And they have to keep you in that plan as long as you want to stay in it. But if you don't enroll within 6 months, or let's say you go to Medicare Advantage and then you don't like that and you drop out, you want to go back and pick up a Medigap or supplemental plan, they can assess your pre-existing conditions, and they can raise your premiums, or they can refuse to insure you. So you can be out of luck. And certainly most people who are 65 or older might be developing some pre-existing conditions. It gets crazier. Look at all the different plans and levels. How could the average person figure out what the heck you even want to go with in terms of these plans? And this basically shows some of the things Medicare doesn't cover completely and how these plans would work. All right. Any questions in the chat room so far? Donna?
Yeah, please go ahead and, nope, I don't see any in the chat room,
Okay.
but if anybody
Now,
has a
this one,
question.
Medicare
Yeah.
Advantage, this one is very interesting. And you see the barrage of advertising on TV to get people to join Medicare Advantage. And what that basically is private health insurance funded by Medicare. Okay, it's another way to get Medicare coverage. But when you sign up for this, you really are going into a private insurance plan. And you must follow the private insurance rules. So now you don't have free choice of doctor, hospital, or provider. You go to whatever doctor, hospital that insurance plan has in their network. Most of these plans have a prescription drug part of it as well. But then you've got to be careful about what's in their formulary. And so we'll get into that with Part D, but I mean, you could get into these plans, and if you're on a very expensive prescription drug, it may not be available through this insurance company. And so that's the other way to get Medicare coverage. We just went through that duplicate. So how is Medicare Advantage funded? This is very interesting. Medicare, original Medicare, takes their funds and transfers them every month to your private insurer. And that's called capitated funding. Regardless of whether you're sick or you use any money or any funds at all, the private insurance company gets the money. And that's the capitation. And that capitation is calculated on how much Medicare is paying out per individual in a given geographic locality. And I've got the numbers here. For 2020, actually 2021, the Medicare costs in various states varied from $883 to $1,168 a month. That was 2020. Colorado, it's $985 a month. So that means Kaiser or United Health or whatever company you're with in Medicare Advantage, they automatically get basically $1,000 a month from Medicare. But the private insurers were not happy with this. They said, hey, we have this administrative overhead. And so you need to give us additional money. And we're going to get to that in detail in waste, fraud, and abuse. So originally it was 17% on top of this that they were being given for administrative overhead. And then they said, well, hey, we could get some really sick patients that are going to be very expensive. And so we're going to need more money for them. And the federal government and the law or whatever agreed. Well, and that's called risk adjustment. Fraud is rampant here. We're going to get into the details when we get to session 3. So this is a ripoff of Medicare dollars to the private insurance companies. And we're going to talk a lot about this in waste, fraud, and abuse. So what are the eligibility requirements for Medicare Advantage? You obviously need to live in the private insurance plan area. You got to be paying your premiums to Medicare Part A and B. You can't have kidney failure and be on dialysis. The kidney is the only organ guaranteed health insurance in our country. So no matter what age the person is, if they have kidney failure and on dialysis, it's covered by Medicare. Unless you're an undocumented person, then you're not covered by Medicare. Then you come to our ER once a week for dialysis. We admit, and I got to be friends with a lot of these folks at Denver Health. We admit them for emergency dialysis. It costs, and somehow they can get emergency Medicaid funds to pay the hospital, which was $5,000 each time. Or if they had outpatient dialysis, it would be $1,000. So the kidneys are well covered in our country, but no other organ. You got to give obviously your health information. You got to follow all their rules about who's in network, who's out of network. And you can only belong to one plan at a time. One of the protections in Medicare Advantage, you still have some of the Medicare protections, and that really does prevent you from getting huge surprise bills. And it may include prescription drug coverage. Most of the plans do, and may include extra benefits. Here's some of the extra benefits. I mean, this makes it very attractive, doesn't it? Eye exams, dental benefits, usually basic exams and maybe some restorations, maybe not. Some of the payment for hearing aids, eyeglasses. They're into meals. I don't know how that works. Transportation, bathroom safety. Well, I guess they come out and check your bathroom out. But anyway, but the latest one is they're getting you rebates on your Social Security of $148 a month. And that tells you they're getting a heck of a lot of extra money from Medicare if they can rebate money to you to be in their plan. And of course, you don't pay any premium. The out-of-pocket limit for Medicare Advantage is $7,500 for in-network care, and a total of $11,300 for in and out of. So there's protection there if you go out of network. How does insurance companies maximize Medicare Advantage profits? Well, they cherry pick. They're not going to recruit people to join Medicare Advantage who are living in nursing homes or who are living in a hospice facility. They're going to cherry pick healthy people. They're going to go to the gym clubs. They like to enroll patients who are eligible for care through the Veterans Administration, figuring that these people will get a lot of their care through the VA. The private company will get all the capitated payments, but have little medical payments out. And they want to enroll people with what they call chronic conditions, but actually less expensive ones. For example, mild arthritis, bronchitis, some other issues, because now they can get increased risk adjustment subsidies. We'll get into this in more detail later. They're very good at lobbying CMS and Congress. The Medicare Advantage subsidies under Obamacare were supposed to decrease every year. Guess what? They've increased every year. Go figure, huh? Now, this is the last one I'm going to talk about. Let's take a break. We're at an hour. Let's take
All
5.
right, should we take a 5-minute break, everyone, and
And we'll
take a
come
break?
back. We'll answer some questions if you have any. And I'm going to
That
go on to
sounds great.
Medicare Part D and Obamacare.
So straight up 6 o'clock, everyone, come back shortly thereafter. Thanks.
Donna, am I going too fast? I have a lot of stuff to cover. I guess she's taking a break.
All right, is everybody ready to get going again? All right, you can get going, Vince. I don't know if you saw it, but in the chat, Lydia put a comment that the session is really good and she thanks you.
Oh, well, thanks, Lydia. I'm getting a little hoarse here, so I won't be able to sing tonight. Okay, let's go on now to Medicare Part D. This is fascinating. Back in, I believe it was 2006, then President Bush said, you know, we have a problem with Medicare because a lot of the people on Medicare are getting prescriptions and they can't afford them. And they're not getting them filled and they're getting sick, and we got to do something about this. So along comes Billy Tozen. We're going to get into him. He was in the House of Representatives. And he says, well, yeah, we got to fix this. And we're going to develop this program called Medicare Part D, where Medicare is going to start paying for prescription drugs. And so the first thing they did was had the drug company write the bill. Not a good idea. And essentially that's what happened. And they made it an unfunded mandate. Here's an additional expense to Medicare, significant additional expense, but they put nothing into how we going to fund it. So they made it an unfunded mandate. Not only that, they had the CBO, Congressional Budget Office, had information about how much it would really cost, and they hid it from the legislators who were considering the bill. And so the bill got passed in the middle of the night by one vote. There was arm twisting. There may have been money passed around. And this is, so Medicare is going to start paying for prescription drugs, but you can't get your prescription from your doctor, take your Medicare card and go to the pharmacy and get your drugs. Can't do it that way. Why not? Well, because the private medical insurance company said, we want a cut of this action. And so what they said was, you have to go out and you got to contract with a private insurance company to be able to get your outpatient prescriptions. How crazy was that? Because now you have to pay an additional premium to a private company to be able to get your prescriptions filled through Medicare. Just craziness, but it's still that way. You either have to have a private Medicare Part D insurance company, or you have to have Medicare Advantage, or some Medicare supplementals will cover it. But this really is crazy because each of these companies have their own formularies. So you have to be real careful that the prescriptions you're on, you go to the right, you contract with the right company, and hope that in the middle of the year, the doctor doesn't change your prescription and it's not covered. So it's available to everyone with Medicare. You don't have to, unlike Parts A and B, you don't have to pay Part D premiums. And you got to have the private insurance plan. So that's called the Medicare Prescription Drug Plan, or you got to be in the Medicare Advantage that has the coverage. It's a broken, crazy, screwed up way to get your prescription drugs. Now, they also created, and nobody knows why, a donut hole. So what happens is you pay your deductible up front for your prescription drugs. And then they start covering them up until, at the current time, you get to $4,020. And after your drugs meet that threshold, you got an out-of-pocket cost between $4,000 and $6,350. You're out of pocket for that. And then after you hit the $6,350 threshold, they start paying for them again. How screwed up is this? But that's just what it is. Now, this donut hole has been shrinking. And the reason it's shrinking is Congress keeps threatening the pharmaceutical companies to allow Medicare to negotiate drug pricing. And their trade-off is, well, we'll shrink the donut hole, make things more affordable. The costs vary by plan, and this is the way it works. Now, and this is the premiums. It's $1,230 per month, plus your private drug insurance premium. And that could be another $40 or $50 a month. Seniors have no idea how to choose among, there's 530 of these plans out here. There were as many as 2,000. And you got to figure out which one is best for you. I tried to do this for my brother, and it made me crazy. And I kind of know a little bit about this stuff. Now, this is the sleazeball who pushed this bill through with these provisions in it and got it passed. But guess what happened? Within 3 months of him doing this, he quits Congress and takes a job as the highest paid lobbyist for the pharmaceutical industry. Not only that, another 12 or so of his and other Congress people's staff who pushed this bill quit and started working for the pharma. This is oh, the other thing about this bill, I forgot to tell you, but I will now, is there's a provision in there that prohibits Medicare from negotiating drug prices. So they can't, the biggest insurer in the country cannot negotiate prices with the pharmaceutical companies. They essentially have to pay their retail price. And if they could negotiate like they do in Canada under their Medicare plan, the CBO estimated the cost saving over 10 years would be between $450 and $530 billion if they could just start negotiating drug pricing. So I'm done with Medicare. If there's any questions or comments about that?
Any questions, anyone? Let me see. I'll look in chat right now, Vince. It says, Jeff Dolman said, I have been working on healthcare reform since Amendment 69 Colorado Care, and this is among the very best presentations I have seen. Will these slides be available for download as a PDF? I'd like to have this for review and for reference if and when I write an op-ed or letters to the editor. So Vince, there's your question.
I will put these on the Healthcare for All Colorado Foundation website and make them available for anybody who wants to use them.
It is a terrific amount of information, good information.
Okay. And unfortunately, as good as some of our providers are, we can't cure stupid. There's no vaccine or transplant available for that yet. All right, let's go into Obamacare. The real name for this is the Patient Protection and Affordable Care Act. And you know, they call it the Affordable Care Act, but the real important part of this is the patient protection part. Back when it was passed in 2010, remember Obamacare, the Democrats just lost the election because the talking point was this was socialized medicine. The government was going to take over your health care, and this was evil. Obama unfortunately did nothing. If he would have stood up and talked about the things I'm going to tell you here in a minute, the people would have started to understand how good this was, rather than having to wait another 9 or 10 years to figure out they didn't want it taken away. And so I'm going to talk about the good, the bad, and the ugly with this law. Okay, let's go to the good first. Here is the major positives of this law. Number one, it prohibits rescissions. Now, what are rescissions? Let me give you an example. A self-employed woman is paying private health insurance out of her own pocket for years. She's age 40 and gets diagnosed with breast cancer, an expensive disease to have. The insurance company goes back to her original application and gets her original medical records and says, at age 15, you had acne, you're on a prescription drug, and you didn't disclose that to us in your application. And so they withdraw her coverage. That's what these companies would do because they are evil. And if you don't believe me, read Wendell Potter's book, Deadly Spin, and he'll tell you all about that. So this is now prohibited. They can't pull that kind of stuff. It eliminates the lifetime caps on how much they have to pay out. You know, a policy had $1 million cap. That says people would say, I'll never get to $1 million. I will show you in the next talk. You can get to $1 million within a week or two in terms of healthcare bills. So that's gone away. It requires free preventative health services, including things like mammography and colonoscopy. And people, low-income people, couldn't afford to have these procedures before because they would have to pay a copay or a deductible to get them. Now they're free. All vaccines are free for anybody with anybody with a private insurance plan. They cannot charge you for those. And that's a big deal. Kids can stay on the parents' policy until they're age 26. Before this, they would be off of it when they were 21 for most policies. And so this is very helpful to a lot of people. In fact, it increased coverage by about 10 million people being able to keep the kids on the policy. It's expanded primary care and community health centers, which are the safety net in this country for people living in rural areas and in poor parts of even the city. Like Denver has about 8 Denver Health community health centers around the city. And everybody knows about this. They cannot exclude you from getting the insurance because you have a pre-existing condition. And these things were really crazy. Let me give you an example. I had an associate who retired early from Denver Health. You could retire when you were over 55 if you met certain requirements for how long you worked. And so he had land up in Montana on Flathead Lake. He was going to build his own retirement home up there, and he retired. And then he found out there were only 2 private health insurers in Montana. Neither one of them would insure him. When he said why, they said, you're over 55 and you're on a prescription drug and we won't insure you. So guess what? He had to sell his land. Now living in Colorado and Brighton, and because he could get health insurance through the retirement plan, but he couldn't get it out of state. That's how stupid some of these pre-existing condition exclusions are. It limits the insurance company's overhead to 80-20. In other words, for every dollar they take in premiums, they have to pay out at least 80 cents for healthcare. And if they pay out less, they are supposed to rebate these premiums to the people who paid them. Now, there's a lot of games played with the accounting here, but they actually have rebated money to people in some of these plans. So they can't keep, 50% anymore. And then this is the way they made it affordable, by having government insurance subsidies to private insurance companies, okay? Originally, the subsidies went up to 400% of federal poverty level. Now they go beyond it, and I'll show you why. They expanded Medicaid, we talked to this, to 138%. And originally we're giving 90% paying 90% of it. And now with the Rescue Act, they're paying 95%. And this one, remember, President Obama got in so much trouble because a president actually lied to us, they said. When he said, if you like your private insurance and your doctor, you can keep it under our plan. Well, he was given a little bit of bad advice. He should have said, you can keep it if it meets our essential basic elements as a quality plan. And so they started telling people who were buying junk insurance, and it really is junk, you can't no longer have this insurance policy, and therefore Obama lied to us. I just can't believe a president would lie. So here are the essential health benefits that are in Obamacare: outpatient care, emergency care, hospitalizations, maternity and newborn care, mental health and substance use is mandated to be covered, but private insurance companies don't do a great job with that. Prescription drugs need to be covered. And again, this gets complicated, but it is rehabilitative services, laboratory, and then preventive and wellness services. So those are the 10, and pediatrics, of course. Now, kids do have, there's a provision now where private insurers have to pay for basic dental care and vision care, but only for children, not for adults. So that's the essential elements. Now, here's what starts to get interesting. How are the premiums determined that you have to pay? But you're buying a private insurance company, a plan that's subsidized by the federal dollars. When you go to the website to say, I want to buy private insurance through the exchange, either your state, if they have one like Colorado does, or through the federal government exchange for states who have no exchanges, they're going to ask you how old you are. And the reason for that is the older you get, the higher the premium can be, and it can go up to 3 times what a young person pays. They ask you if you smoke. If you smoke, you get an increased premium. They want to know your zip code because that's one of the ways they determine what your premium will be. And in fact, it can be 3 times higher, 2 to 3 times higher in a rural area compared to an urban area. For example, in Summit County or in the ski country up in the hills in Colorado, younger people were paying 2 to 3 times as much for the same premium that someone could buy in Denver. And the reason for that is there are fewer providers up there. So insurance companies can't go and negotiate discounts between 2 or 3 hospitals. For example, I know an executive administrator from Vail who told me right off, he said they come to us to negotiate. We tell them to take a hike because we're the only act in town and we're going to charge whatever we charge and they have to pay it. And so insurers don't like to work in rural Colorado. Now, there's some new laws and new things that have changed this and improved it, but it's happening all over the country. And they then will ask you, what is your estimated annual income to be this year? And based on your income, projected income, they calculate your subsidy. And
excuse me, Vince, would you admit Eleanor to the room again? She lost her connection.
Oh, sorry.
That's okay.
Okay.
Thank you.
And the important thing that the politicians deceive everybody about Obamacare. They're making it like the government is setting the premiums and the premiums keep going up. The government isn't setting them. The private insurance companies set the premiums. And this is a corrupt deal, and I'll get into why. There are 4 tiers in Obamacare. And you can see the higher up you go, the greater the premium and the more that's covered. Now the American Rescue Act comes in here. That was passed right after Obama was elected, or Biden was elected. And in that Rescue Act, there's a 29% spending hike in Obamacare subsidies. They really have made insurance through the Obamacare exchanges very, very affordable. And here's how they did it. They put in actually $40 billion in subsidies that expired in 6 months if they're covering COBRA, to 2 years if they're covering enhanced subsidies. That I don't know why they did this, but COBRA, of course, is that's a law that says if you lose your job, you can continue with your current health insurance that you got through your employer, but you have to pay the premiums. So this Rescue Act said, well, we'll pay 100% of your COBRA between April 1st and September 30th of this year. That's running out soon, but they're The government's paying 100% of COBRA for people who have lost their jobs and had private insurance. They reopened the marketplace. That's only open usually from December to January each year. And they opened it from February until August 15. It goes away in 3 days. They increased Obamacare subsidies and eligibilities. They said it will insure at least an additional 1.3 million. It's more than that. It enhanced the Medicaid subsidy to 95% to try and encourage states to expand Medicare. So what's the shortcomings here, though? Well, there's a perverse incentive here. The higher the premium, the more money the private insurer gets. So there's no incentive to control costs or to decrease premiums. The incentive is just the opposite. The higher the premium, the more money you're going to get from the government and from the individual based on a formulary I'm going to show you. Biden campaigned on he was going to expand Medicare down to age 60. Not in the law. It hasn't happened. Is it going to happen with the new proposed law that they're talking about? I don't know. I hope it does. But all of these subsidies, COBRA sunsets September 30th, but all the other subsidies sunset in 2 years, which when that happens, premiums are going to rise dramatically for individuals. And so they're going to try and put more money in the new law that they're proposing with $3 trillion plus in it that will cover these subsidies. So that's how Biden is addressing affordability of health insurance. He's throwing billions of dollars at the private insurance industry. And this is the current federal poverty level. And you can see for a family of 4, it's about $104,000. For an individual, it's what I can't see it on my slide. It's 56 or 50 some thousand. And here's what they did to increase the subsidies. The left-hand column shows you the original formula. And those percentages are a percent of your annual income. So if your annual income, if you're lower than 130% of federal poverty, your income is probably going to be, for an individual, $20,000, and you end up paying 2% of that. That's your premium. If you're up to the 104,000 threshold or just below it, you're going to have to pay 8 to 9% of your income. So, for example, a family policy right now costs about $25,000 a year. If you're making, let's say, 100,000, you've got to pay up to 10% of that. So that's a good deal because you're paying maybe $11,000 for a $24,000 insurance policy. That was originally, but now look what they've done. If you're 400% of poverty, they've decreased that even more. And if you're above 400%, you can still buy a policy at 8.5%. So a $25,000 policy for a $200,000 a year earner, he's going to be paying about 17 or 18,000. So they're still having the government subsidize private insurance even for the high wage earners. So that's really a good deal what they've done. But these subsidies go away in 2 years unless they continue them. But you can see now why private insurers have absolutely no incentive to control costs and premiums. They have an incentive to raise them as much as they can because they make more money. So how does the private insurance companies maximize profits? Well, the big one here, insure the healthy and avoid the sick. Now, the fact that they can't deny insurance for a pre-existing condition has taken away some of this from them. But there's other games they can play here to do this. Negotiate discounts with providers and hospitals, pre-authorization approval for tests, studies, procedures. They have to be pre-authorized, otherwise they're not covered. They can deny or reduce payments for things that are provided. They highly control their networks of providers and hospitals, and it's the ones where they negotiate the highest discounts. It's not based on quality, it's based on money. And there is no free choice of doctor or hospital. And the politicians are really good at implying the no free choice comes from Medicare, but the private insurers are wonderful. And they can limit the drugs in their formularies so that some of the most expensive drugs, and we're going to get into the new Alzheimer's drug a little while later. Boy, that one can break the bank, and we're going to talk about that. Anyway, so that's what they do. Now, look at these yellow things don't come through well but they're 10% percentiles, okay? And this is the percent of healthcare costs. If you look at the last bar here, you can see, I've got it blocked out. Let me see if I can move. Anyway, what is it, 76% or 83%? On that,
It's 73, Vince.
73. So 73% of the money spent on healthcare is consumed by 10% of the population. And if you add the 73 to the 13, you get to 86% of the dollars are consumed by 20% of the population. And look how little the rest of the people spend on healthcare or the costs. So if you're an insurance company CEO, who do you want to insure? Well, you want to insure the green circle here, right? And to think about, this is virtually anybody who can hold a full-time job. That's why they love this employer-based insurance. Because if you can work 40 hours a week, you're probably reasonably healthy. But look at the people on the right side now. Who's insuring those? Well, that's Medicare and Medicaid. That's who's paying the big bills, the most money, where the private insurers are just living it up over here. And this is an important slide. You're going to see it again, because when we talk about how do you make healthcare affordable and save money, is you got to have the healthy in the risk pool paying premiums or taxes or however we do it, along with the sick, so that we can decrease the cost to everybody. But you got to get these healthy premiums, the healthy dollars, into the overall risk pool. And right now, the insurance companies are not going to go for that. In fact, they fight it every chance they get. Now, that was all the good stuff. What about the bad? Well, even with Obamacare, there's still 30 million people who have no health insurance in our country. That has not significantly decreased overall medical costs. There were provisions in the original bill that were supposed to start decreasing costs, and they've been overridden by lobbying. It's increased the federal and state bureaucracies. I mean, the cost to fund the exchanges is incredible. I can't believe how much money it costs even to fund the exchange in Colorado, but then the federal exchanges. So they've created more bureaucracy. They've excluded undocumented immigrants, where other countries call these people, they call them workers, and they insure them, guest workers, and they provide health insurance. But think about it, they still need health care. And what happens is they can't get ongoing primary care. So they come to the emergency room when their diabetes is totally out of control, get admitted to the ICU, run up the huge hospital bill that most of them can't pay. And it just cost the system so much more money than if they could get primary care, or they get no prenatal care and come and deliver a premature infant who stays in the NICU for 2 or 3 months, where maybe that could have been prevented with good prenatal care. There's 6 million of those Medicaid eligible remain uncovered because of politicians, because of politics. It's immoral. I can't believe politicians would deny health insurance to people when 90% of the premiums are coming from the federal government, and their people in their state are paying the taxes to the federal government that's funding these premiums, or these, the Medicaid premiums. It makes no sense to me at all. It's bad. It's horrible for the patients who aren't getting coverage, and it's horrible for the providers who can't get paid. There are still 50 million underinsured. What does that mean? They have health insurance, but they can't afford copays or deductibles because they're too high. They can't afford them. That's underinsurance. Medical bankruptcy, we'll talk about next week. That continues for us to be the only country in the world where it happens. And we talked about incentivizing private insurance companies, and certainly it will not generate enough revenue to offset costs. It has to be subsidized with billions of dollars. So it's a broken system. The unintended consequences, think about it. Why would an employer now, you got a guy making $50,000 a year, and the coverage for his family is $24,000. The employer was picking up 70% of that cost, and the employee was paying 30%, where he could go on the exchange and get the federal government to pick up 80% or 85%, and he paid, well, no, it'd be a lot more than that, 90%, 95%. And then he pays the other. So the employers are encouraging people to drop their coverage through the employer because it's costing both the employee and the employer more, especially the employer, and go on the exchange and let the federal government subsidize the insurance. And then, of course, the individual mandate, which was in the original bill, that said anybody who refused to purchase private health insurance would have to pay a penalty, which was not very high, but it was real. The Supreme Court also took away the individual. Well, no, actually, the Trump administration took that away in the tax law. They removed the individual mandate. And so now you have people who pay no penalty, the young, healthy invincibles, and say, I don't need health insurance. And so you end up with a sicker risk pool and more premiums. Now we even get into something more ugly. This is the Lancet, which is the premier medical journal, one of the two from Great Britain. And it talks about the corruption by corporate influences in making policy in our country. And here they were talking about healthcare. So when Obamacare proposed this, he had two choices. He says he didn't want to start from scratch. So he had two fundamental choices. One is to build on what we already had, which was Medicare and Medicaid, or build on the private sector. And because of the huge special influence, special interests, of course, he went with the private sector, and that's why we have Obamacare. The lobbying during the year 2009 was incredible because everybody wanted their part of the action to be protected, and then how could they figure out how to make a lot more money? And this just shows you how much cash was sent in here just to lobby this. And again, the insurance industry were the major force behind the law. And pharma, of course, got into the act as well. And So we can move on to questions, comments. We've got plenty of time to discuss other issues or anything that wasn't clear. Are there any out there, Donna?
Just a minute. Yes, hang on just a minute. Let me read you some of the chat comments, Vince.
Okay.
Shelley asked that if anyone is in CD6, Jason Crow's district, please email him to say you support Medicare for all. Crow has supported Medicare X, which is not the best option. Almost all primary care physicians these days are owned by the same for-profit corporation or private equity group. Otherwise, you have to pay for direct primary care, basically the boutique practice. As a retired pediatrician, our marketplace keeps pushing me for Medicare for all. Even Obama's private physician in Chicago pushed for Medicare for all. That was from Shelley.
Yeah, she makes some very important, pertinent comments, and we're going to get into some of these issues in the next couple of next sessions we do.
Yeah, I don't see any other questions. Do other people would like to unmute their lines and ask any questions or make comments? And we want to make sure that we are somewhat orderly. So there is a little function that's near where you type in the chat where you're allowed to raise your hand if you want to make a comment or ask a question. That's really effective. Or if you'd like, as long as we're not stepping on each other speaking, just speak up and say who you are and what you'd like to say or ask.
Yeah, the important point here is about the private equity hedge funders taking over. I mean, taking over medicine. Over half of the physicians in the country now are not in their own private practices. They're under the umbrella of either a hospital, a private hospital, often for-profit hospital system, or a private equity investment firm. And this is dramatically driving up the cost of medicine, of medical care, because of the great inflation in medical billing. And we'll get into that in some detail. But that's really corrupting medicine these days. And doctors are being driven to this because they can no longer stand to be negotiating with private insurance companies. It's very expensive, it's very time consuming. So they're now taking a job where they're salaried and they don't have that administrative hassle. But often their incomes are going down because the private equity for-profit vultures out there have to take a lot of money off the top. So it's a bad situation. But
yeah, and Vince, I have a question really quickly. What do you think the impact of the pandemic's going to be on our health policy? What do you think ultimately do you think we're going to reach any closer to believing we have to have a universal system?
Well, the little universal system here, the government's thrown billions of dollars at developing the vaccine and now buying it and making it free to everybody. But, I don't know. I don't think it's gonna change things very much because of the tight grip the private insurance companies and the hospitals have on what's happening in healthcare right now. Yeah, I don't know. I don't know about the pandemic. It certainly has caused a lot of healthcare bills that people can't pay because all you get is the vaccine free. You don't get any of your medical care free, and you lose your job and lose your insurance. It's going to increase.
Yeah, I saw an article yesterday that was published in the New York Times talking about the volume of lawsuits coming from hospitals and providers right now has gone through the roof with medical bills, because just what you're saying, people have had enormous medical bills that they have no way to pay. And
Yeah,
it's just,
and the hospitals owned by, particularly the for-profit hospitals, will take people to court. They'll garnish their wages. They'll try and get their homes. And it's a horrible situation of what's going on now. And it's only going to get worse because of the people running up these huge medical bills, especially if they end up in the ICU for any period of time. Yeah, you know, I think it's gonna, if anything, it's going to accelerate the implosion of our healthcare system, and that's where we're headed.
well, that sounds kind of scary. I think we better tune in for your next 3 sessions so we can figure things out.
Yeah, well,
If anybody,
Yeah,
go ahead, Shelley.
yeah, I was just gonna say, I think it's so important to contact your Congress people, because I think most of them have signed on for Medicare for All. That's why I put the comment in about Jason Crow, because the other hat I wear is through Progressive Democrats of America, as you do. And we're working on Jason Crow, and he's sort of sucked into the abyss of Medicare X with, you know, he's a relative newbie, so he's following Bennett. And of course, I'm sure Hickenlooper is, that he's never been one of our allies, but moving right along. I mean, we need to pressure our legislators, because so much of this is political, and you know, it gets back to the whole Citizens United and the lobbyists and the money in politics, all the stuff you've talked about in so many of your presentations. And I want to just thank you, Vince, because you are relentless with this. I mean, a lot of people will just give up and go golfing, although I can't imagine anything more boring, but whatever. Sorry, Donna, I know Larry loves to golf, but whatever. You know, as what's his face wrote, I forget his name now. He used to be he's a commentator. Anyway, he wrote a book, Golf, A Good Walk Spoiled, you know, so anyway. But
Yeah, it's a tough situation for a lot of people.
yeah, we have to keep pushing, you know, supporting Jamila,
well, I think
Pramila Jayapal and Ro Khanna, and people who are supporting Medicare for All. And Jason Crow he's a tough nut to crack. I don't even know if he'll still be in our district. I looked at the districting maps, but it didn't really have the congressional districts nationally. It was more the local.
Well, I think the only thing that's going to overcome the huge special interest lobbying dollars is people who really understand the issue and will vote. That's the only way you're going to overcome. And there's going to be enough people who simply can't afford healthcare. I mean, it's just going to happen.
Right.
And they're going to get, if they get upset enough and get enough people educated and involved, and hopefully that's what this will do, is educate some folks.
Right.
Once you follow
I see
money,
Lydia.
no
Lydia
matter
has
what
her
your
hand up.
political persuasion, when we follow the money, you get it. I
Right.
think you understand.
Mhm.
Vince, Lydia has her hand up. Lydia, would
Yeah.
you like to make a comment or ask a question?
One of the questions is the one you asked about the COVID situation costs, but I have a couple of other questions, and that was one of them is there a shortage
Is there what, Lydia?
of doctors and medical professionals? And is there a shortage of doctors and medical professionals right now and in the future? Because the way that medicine and the presentation that Vince just outlined, is that impacting their decision to become doctors and professionals?
Well, there's a shortage. There's a
Primary.
shortage of primary care providers, a great shortage, because the money is in specialty care.
Right.
And of course, medical students run up $200,000-300,000 in loans easily to go through medical school. And the way they see to pay them off is to go into a high-paying specialty. So we have far too many subspecialists. Often the fees they're charging are exorbitant, and we have underpaid primary care doctors and mid-level practitioners. And so we need much more primary care. And we're going to get into a lot of this when I talk about waste in medicine and some of the abuse. And Yeah, it's imbalanced here. We don't need it. We have far more technology than we need. We don't need a CAT scanner in every corner or 40 freestanding emergency departments in Colorado. And that one makes me pretty crazy, and we'll get into that. I mean, why should you have a freestanding emergency department 2 or 3 miles from a hospital emergency department? And it's because it's from a competitor hospital who are trying to steal patients. I've got a freestanding ER a mile down the road from where I'm sitting, and it has a helipad. And the freestanding ER is 5 miles away from their own hospital, St. Anthony's. Now, why the heck do you need a helipad? Because you can charge a heck of a lot more money if you put a patient in a helicopter.
Oh, yes, thousands of dollars.
We're gonna get into helicopters. That's kind of fun too. The private equity hedge funders now own 80 to 85% of all the medical helicopter services in the country.
Oh my gosh.
The average cost of a medical helicopter ride is $40,000.
Lydia, did that answer your question? You need another question?
I have another question too, Vince. And it intrigued me when you went over the Medicare Advantage plans.
Yeah.
And how if people want to come off of them and to like, they just signed up because they thought it was the best thing, the best policy or the best choice for them because they're working and all that. But then they decide, I don't want to be on it. I want to go back to regular Medicare. You stated that it would be difficult for them. And I guess
you can go back to regular Medicare anytime. What you have problems with is buying a Medigap or supplemental insurance policy.
yeah, that part, that 20, that's the one that covers the 20%, right? That
Right.
Medicare doesn't cover. How is that constitutional? How is that not a lawsuit?
Well, Obamacare didn't anticipate it when they wrote the law. So the pre-existing conditions only apply to policies you buy, private insurance policies you buy for full coverage. It doesn't apply to supplemental policies, and that's how they get away with it.
Can the law be changed? It would
Sure
be
it could,
really
but
difficult to
The
change.
special interests are not going to go
Block it.
for it.
I got it. Okay, thank you.
All right, well, I think we can probably end and
I'd like to, may I say something?
Yes, Eleanor.
Yes, of course, Eleanor, go ahead.
The PNHP annual meeting is going to be here in Denver on October 23rd. Is their all-day session from 9 a.m. to 9 p.m. And I would suggest you apply and register because they're going to have a lot of programs and they are supporting the Medicare for All plan proposed in 2021. So I think there'll be lots of good discussion, and I think it'd be a great way of updating what we know.
Yeah, it's a national meeting that you don't have to travel to, which is nice.
Right, right.
Okay. All right. Well, thanks, everybody, and we'll pick this up next week.
Thank you, everybody. And remember to tell your friends. We'll watch for the people who registered and didn't make it this week. Thanks. Have a good evening. Thank you so much, Vince.
You're welcome. Bye.
Bye.
Well.